I would like to start by welcoming you to the 2017 Health Equity Symposium. I am Mary Fleming. I'm the president of the Reed Scholars, and this is our signature event. This is our 8th annual Health Equity Symposium. As you know, this year we will be focusing on oral health, and our theme is Integrated Care, Oral Health's Role in Equity. We have a great panel that I think you all are going to enjoy listening to, regardless if your field is oral health or not. And this is a great way for us to work on, the key word here is integration across disciplines. Cynthia Hodge, who is our symposium committee co-chair, is going to come up in just a few minutes, and she will give a few words of overview and then introduce the panelists. And they will all have the opportunity to give a short presentation, and then that will be followed by a discussion.
Good afternoon. And I join Mary in welcoming you to our Reed Scholars Annual Health Equity Symposium. My job is, the moderator's job, I should say, ordinarily, is to introduce the speakers and tell you a little something about them. Well, because our time is short today, I'd like to refer you all to the program, which has all the information about all of the speakers, and you'll find their very impressive bios in the program. So instead, what I'm going to do is provide some context for today's conversation. The focus of our discussion today is on oral health and integrated care. And we've heard a little about that earlier today. Integration of oral health and primary health care is one goal in a framework to achieve health equity. Health equity being that space where every person has the opportunity to attain his or her full health potential, and no one is disadvantaged because of their particular circumstances. General health and wellness are inextricably linked to oral health. It is impossible to have one without the other. Most dental craniofacial conditions are multifactorial, arising from complex biological, environmental, and behavioral influences. Pain, diminished function resulting from oral diseases negatively affect one's quality of life. We also know that poor oral health is associated with increased systemic bacterial exposure and increased inflammatory factors that can lead to uncontrolled diabetes, cardiovascular disease, and respiratory disease, among other effects. The contribution to end-stage renal disease and preterm births have also been studied. More than 4 decades ago, the publication Healthy People, the Surgeon General's Report on Oral Health Promotion and Disease Prevention, described the first national health agenda. And while we experienced some improvements in health, it wasn't until the Surgeon General's Report on Oral Health in America, published in 2000, shone a light on the social and economic impact of poor oral health. This was soon followed by a national call to action to promote oral health in America. Numerous other workshops, publications, studies, investigations have since occurred, all culminating in the Oral Health Strategic Framework 2014-2017, developed by the Health and Human Services. And as you will see, the first goal of the Oral Health Strategic Framework is integrate oral health and primary health care. So that's what we're going to talk about today, that first goal. The second goal being to prevent disease, third, increase access, 4, increase dissemination, and the fifth goal being to advance oral health and public policy and research. So we are very fortunate today to have many of the chairpersons of those work groups, sponsors of some of those works, pioneers in some of these works here today, to share some insider views on what took place, how the concept of oral health and primary health integration came about, The first speaker is Dr. Caswell Evans, and he's going to describe for us what integrated care is. Dr. Evans, do you want to come to the front? Next, we will hear from Dr. Bruce Donoff, who will tell us how academic institutions are transitioning from a traditional curriculum to a more medical dental curriculum to prepare oral health professionals for integrated services. Then we will have a clinician, Dr. Isang. Do you want to come to Dr. Donoff and Dr. Isang? Dr. Isang will describe a clinical practice that is integrating oral health and primary care. And then we'll have Mr. Ralph Fucillo talk about payer-provider integration to ensure optimal oral health. This will be followed by my fellow Reed Scholar, Dr. Brian Swan, who will give us some thoughts on his concept of what we as oral health care providers should really be about. So with that, again, I refer you to the program. And we'd like to hold, unless you have a burning question, hold it to the end because we've allowed an hour for questions and answers and a conversation. Dr. Caswell.
Well, good afternoon, everyone. Thank you so much for inviting me. I'm very pleased to be able to participate in the Reed Scholars Annual Health Equity Symposium. A number of older friends and younger friends are in the audience, so it's very nice to be here. Some of my comments will follow and embellish on Dr. Hodges' comments. But I'd like to start by just pointing out that words are our exchange of information and ideas. They are powerful symbols. And as we use these words, images come to mind. And so when we talk about health and we talk about our health system, these powerful images come to mind. But when we think about it and we look at the definition of, let's say, system, if you look at Merriam-Webster, for example, you'll see system is described as a group of entities working in high levels of collaboration and syncope, all focused upon a common objective or a common outcome. And so when you take that type of definition and compare it to our health system, you tend to go blank because we know the health system doesn't work that way. Now, on the other hand, we do have a pretty good disease treatment system, and the disease treatment system probably fulfills that definition a little bit better than our health system. We should also keep in mind that the World Health Organization, I think I'll move a slide here. The World Health Organization describes health as the state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. And that word complete is really the operative term, because for it to be complete, oral health really must be within the contours of health. So in that context, oral health is part of that definition and should be considered along with mental health, physical health, heart health, and other bodily functions. Okay, we do it there. Okay, great, thank you. Now, the definition of oral health is particularly helpful, and the Fédération Dentaire Internationale, which is the major international organization that tends to represent all of the dental organizations worldwide, has developed this definition, and I must say it's somewhat crafted on the Surgeon General's report on oral health, which has already been mentioned, and I will mention again in a few minutes. But the FDI's definition is very helpful. Oral health is multifaceted and includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expression with confidence and without pain, discomfort, and disease of the craniofacial complex. Now, that's a very long definition, but I think the significance of that definition is to point out that this definition goes well beyond teeth, which we often think of in terms of what oral health is, and it also goes well beyond dentistry. So we need to think about oral health in terms of these larger manifestations, and these larger manifestations clearly place oral health well in the context of general health and welfare. Now, dentistry does entail numerous procedures to prevent disease, protect against insult, to repair structures, and to restore function with the intent of achieving and maintaining oral health. However, dentistry and oral health are quite distinct. Education and practice silos have resulted in the typical model of oral health and dental practice as being somewhat outside of the health system. This separation has led to substantial health inequities among population cohorts and has resulted in disparate health status among them. Now, if we look at the disease, the common disease, dental caries, or what are seen as tooth cavities, the data make it clear that large populations do suffer disproportionately. These include racial and ethnic minorities, including immigrants and those who are non-English speakers, children, especially the very young, pregnant women, people with special needs, older adults, individuals living in rural and urban and underserved areas, homeless individuals, and people who are institutionalized, populations of lower socioeconomic status. Now, if you're not among these population cohorts, you have a pretty good chance of benefiting from relatively better oral health. However, some of these people do in fact fill two or more categories. For example, young children in families with lower socioeconomic status. Importantly, when taken together, this list of population cohorts represents roughly 2/5 of the US population. And this is the population that displays oral health inequities. Now, when we think about inequities, it raises the question, particularly in oral health, does the oral health care system represent social justice? How can these inequities in oral health be ameliorated? And we know that where inequity exists, extra steps must be taken for those who are affected. It can be said in our current oral health system that the population relatively least in need of care receives the most care, and the population relatively most in need of care receives the least care. Now, without getting into the weeds of a lot of data, I just do want to share this information with you to put this in an additional perspective. 1/4 of children 2 to 5 years of age and half of children 12 to 15 suffer from tooth decay. 1/4 of adults 20 to 64 years report having untreated dental caries. 1/4 of adults 65 years and older are edentulous, that is, they have no teeth. Oral and pharyngeal cancers, often diagnosed too late, kill nearly 8,000 people yearly, and that's nearly double the number of women who die from cervical cancer each year in the United States. In 2010, Americans made 2.1 million visits to hospital emergency departments for dental conditions at an estimated cost of well over $1 billion. We also know that there are bimodal effects between periodontal disease or gum disease and diabetes. Diabetes exacerbates periodontal disease, and periodontal disease exacerbates glycemic control in diabetic patients. Now, studies that, and Dr. Hodge referenced this as well, studies conducted by the health insurer United Concordia, based in Pennsylvania, have shown that the medical costs associated with care of diabetic patients were significantly lower for those patients who received the periodontal regimen compared to those patients who did not. The United Concordia data also showed substantial medical care savings for other conditions as well. These findings have been substantiated by additional studies. Now, the gulf between the medical side and what we call the health system and the oral health side have been recognized and criticized over the years. The Surgeon General's report on oral health in 2000 was a wake-up call, and it was the first report, as you well know, when Surgeon General's reports are issued, they come to people's attention, even if the subject matter is not familiar to them, it will take out the time to read the executive summary. So this report, for the first time, laid out oral health issues nationally, spoken from the voice of Surgeon General David Satcher. And it was a widely read report with very diverse readership, and it was a wake-up call. The report startled many in its proclamation that there were profound and consequential oral health disparities among our population. The report also noted the challenges that many in our population face obtaining care, highlighting the issues of access to care. Significantly, the report also pointed out that oral health was everyone's responsibility. Certainly everyone in the health domain had responsibility in the oral health arena. And that oral health was inextricably linked to general health and welfare. It stated that greater collaboration between the medical services and oral health services was certainly needed. That report in 2000 was followed by the national call to action that was released by Surgeon General Richard Carmona. So 2 Surgeon Generals in a row having put out reports on oral health. This report was the product of a public-private partnership under his leadership. The report recommended that all health professional training should include oral health, particularly regarding the associations between oral health and general health and welfare. It recommended that all healthcare providers be trained to conduct oral health screenings as part of their routine examination and make referrals as needed. The report also recommended interdisciplinary training so that health professionals could counsel patients about reducing risk factors common to oral and general health. The Institute of Medicine, now known as, or now renamed as the National Academy of Sciences, convened a workshop, the U.S. Oral Health Workforce in the Coming Decade. Now, speakers at this 2009 workshop addressed the need and value of service integration and training for non-dental workforce workers regarding oral health. The Institute of Medicine also put out 2 reports in 2011. First, improving access to oral health care for vulnerable and underserved populations, and the second report, advancing oral health in America. The first report recommended that the Health Services and Resources Administration, that is HRSA, convene key stakeholders to develop a set of oral health competencies for non-dental healthcare professionals. HRSA took immediate action and in 2012 issued the Integration of Oral Health and Primary Care Practice Initiative that outlined this core set of clinical competencies for primary care clinicians, along with implementation strategies. The overarching intent of the HRSA action was to advance interprofessional collaboration, practice, and bidirectional sharing of clinical information. This is the second report. As a further action, HRSA issued its report integrating oral health and primary care practice that summarized overall recommendations regarding core clinical competencies, as well as those related to infrastructure, payment, policy, cost, and program implementation, and evaluation methods. The second report that was put out by the Institute of Medicine in 2011, Advancing Oral Health in America, noted the division between oral health and general health practices and stated the separation is at odds with the fact that good oral health has been shown to directly affect a person's overall health. In 2015, a white paper, Oral Health, an Essential Component of Primary Care, was released by Qualis Health. Development of the paper was made possible through the joint support of three sponsors, the DentaQuest Foundation, the REACH Foundation, and the Delta Dental Service Foundation of Washington State. This support illustrates the interest that foundation boards and their constituencies have in this matter of interprofessional collaboration and integration of oral health into primary care. The paper provided a primer outlining methods that primary care practices could incorporate and how they could incorporate oral health. Due to the disease prevention value of this inclusion, the paper stated, engagement in oral health is a strategy to achieve primary care's goals of improving care of individuals, improving the health of populations, and lowering overall costs. In other words, integration of oral health into primary care is seen as a fundamental action to achieve the triple aim. In 2016, the New York University, under the leadership of the College of Nursing, in collaboration with the Colleges of Dentistry and Global Health and the School of Medicine, convened a national symposium, Transforming Whole Person Care Through Interprofessional Medical Dental Collaboration. The symposium brought together thought leaders from diverse health, policy, research, education, finance, and practice settings regarding evidence-based initiatives and models for integrating oral health and overall health in person-centered care systems. In its Oral Health Strategic Framework 2014-17, the Department of Health and Human Services outlined a comprehensive plan to integrate oral health and primary care within the vast DHHS system of programs and services. That plan includes action steps for the Centers for Medicare and Medicaid Services, for HRSA, for the Indian Health Service, for the National Institutes of Health, particularly the National Institute of Craniofacial Research, the Office of Minority Health, the Substance Abuse and Mental Health Services Administration, the Bureau of Prisons, and Immigration and Customs Enforcement Corps. This is clearly an all-hands-on-deck commitment to integrate oral health across DHHS's primary care and general health platform. So these are some of a few of the key and salient actions that have occurred at the national level, focused upon encouraging and promoting and providing guidelines as to how we integrate oral health into primary care and general health and welfare, pointing out that oral health is in fact inextricably linked to primary care and general health and welfare, and that oral health should be part of the practice regimen and health concern for all health workers. So I will leave my opening comments at that point, and we'll go to our next speaker.
Good afternoon. It's a pleasure to be here, as this is one of my favorite topics. The topic is oral health and medicine integration, a pathway to health equity. That's me. I am, in fact, a clinician as well as dean of the School of Dental Medicine. I operated last week and even took out a tooth this week. but you can see that I had a lot of loans, and that was part of a program that I'll describe a little later on. I just want to highlight two things. The Harvard School of Dental Medicine has a 150th anniversary this year. We just celebrated with a big dinner. And to the point, it started in 1867. First American dental school with a university and a medical school, the first to give the DMD degree, and the first to have black graduates. Dr. Freeman in 1869 and Dr. Grant in 1870. Dr. Grant, by the way, also invented the golf tee, although things weren't patentable then. But if anybody has an in with the Tiger Woods Foundation, let me know. Also, we're very interested in integration, and so we have an initiative to integrate oral health in medicine that I'll tell you a little bit about later. So, just to get us thinking in the same direction, Atul Gawande in the New Yorker a few years ago had a very interesting article entitled Slow Ideas. And he compared and contrasted the introduction of ether anesthesia and aseptic technique, and described how ether was quickly adopted by the medical community. As a matter of fact, its communication probably went faster without the internet than it would have with social media and the internet today. Was quickly adopted by the medical community as opposed to Lister's aseptic technique. And I think this is something we need to consider as we talk about medical dental integration. Some things just take a long time. And the main reason that ether was so readily adapted, it helped the doctor. And it was billable. And it helped the patient too, by the way, as opposed to aseptic technique, which was a bother. They weren't set up to do it, et cetera, et cetera. The other thing I'd like you to think about is the following. Steve Martin, who's a primary care provider in the western part of the state, and Dr. Ilsong knows him well and involved in some of our programs, has been taught how to give mandibular blocks to relieve pain, dental injections. In fact, he gives them with spinal needles. But dentists can't give vaccinations. They can't even give a TB test. You could give a TB test. Yeah. Okay? And last but not least, last Saturday was the Kentucky Derby. And interestingly, there was a lot of commercials. And flicking the channels, I came across the old movie Secretariat. Secretariat was a great horse, won the Triple Crown. But Secretariat was in bad shape after one race, the fall before the spring of the Triple Crown. And it took a veterinarian to diagnose his problem. His problem was a dental abscess. And once his dental abscess was treated, which isn't easy in a big horse, okay, by manipulation and antibiotics, he won the Triple Crown. And it caused me to look up the Practice Act for veterinarians. And it's interesting. Practice of veterinary medicine means to diagnose, prognose, treat, correct, change, alleviate, or prevent animal disease, illness, pain, deformity, defect, injury, or other physical, dental, or mental conditions by any method or mode. It's the perfect primary care doctor when you think about it. Two books that you should read if you haven't. One called Teeth, which isn't a very flattering description of the dental profession, and another called An American Sickness, which is another indictment of capitalism and healthcare. Both of these authors are people I know. Mary Otto, in fact, spent some time up here as a fellow at the School of Public Health. Elizabeth Rosenthal was a reporter for the New York Times. She's now the editor of the Kaiser Health newsletter. But I spoke to her about 5 years ago, so I had a cell number, and I called her. Why did she call me? She wanted some advice for her daughter's wisdom teeth. The other thing that we can't do is we can't charge for phone calls, which is too bad. So, very recently, just to keep us thinking in this line, a group of about 8 very distinguished people in oral health got together in Bolivia, of all places, and issued reports and came out with something called La Cascada Declaration, just this March, which says the following in summary: growth of social inequalities and importance of population health in oral health. Significant levels of oral disease and disability exist globally, with clinical interventions accounting for only a small proportion of health improvements. Insurance companies are increasingly involved in the provision of all health services. There's been a decline in public funding for universities, with research increasingly depending upon industry and public-private partnerships. Food and beverage companies stoke decay, obesity, and diabetes. I once was at a luncheon, and there was a senior executive from Coca-Cola there, and I asked him if any of the bottling plants were in areas of fluoridated water versus non-fluoridated water. And he said he would check on it because I thought it would be an interesting study. He never got back to me. The dental profession is overtrained for what they do and undertrained for what they should be doing. Dentistry should become a specialty of medicine. We should limit specialization in dentistry, and oral health physicians should lead oral health teams. Incidentally, today's Thursday, right? So 2 weeks from today is Harvard commencement. And at commencement, I will present the graduates of the School of Dental Medicine to the president of the university and all assembled, and she will grant their degrees and welcome them in to a demanding branch of medicine. No other school does that. But we're really going to have teams, and we need oral health physicians to lead those teams. And the current state needs each country to assess what they need to do, because underdeveloped versus developed countries, everybody has a different need. Why integrated care? Well, there are lots of external forces driving integration. You heard about the very important reports from Dr. Evans. I should point out that the Surgeon General didn't write the Surgeon General's report, he did. You what? That's right. Poor oral health is definitely linked to chronic diseases, the most common being periodontal disease and diabetes, cardiovascular disease, respiratory disease. There even was something in the Journal of the American Medical Association recently showing a very strong association with rheumatoid arthritis and oral health. The problem is we don't have Koch's postulates kind of evidence for this, that is, that this bacteria causes this. But someday, with all these new genomic techniques, we'll get there. We have better outcomes with lower costs when there's good oral health. You heard some of the studies from United, Concordia, Aetna, a whole host of them. That, in fact, was the reason that we formed this initiative to integrate oral health and medicine, because there seemed to be an economic reason for good oral health, because it limits chronic diseases and, more importantly, lowers costs. Multiple insurance company studies are showing these lower medical costs with better management of chronic disease and good oral health, and there certainly is improved access with enhanced care coordination. Some of this is already taking place. Federally qualified health centers do a magnificent job of making sure patients move between medicine and oral health kinds of things. We were in Rhode Island yesterday at the Oral Health Commission there, and they do some very interesting things in terms of this topic of medical dental integration. Dental disease and medical health problems clearly are interrelated. The safety net population has definitely a higher level of dental disease, and emergency room use is just out of sight, out of sight. The service gap for dental disease in the safety net is huge, and it's getting bigger. You heard some of the statistics. Oral health access is enhanced when provided in primary care settings, and I've added this to every slide because I hate missions of mercy, where thousands of people line up to have their bad teeth taken care of, and the dental profession thinks it's the greatest thing on earth. Oral health prevention and disease management is cost effective when provided in primary care settings. Outcomes for children receiving preventative and disease management in primary care settings are good, and certainly the CHIP program that's been in effect has had a very good effect. More importantly, the one-stop shopping model of care is a proven plus. And once again, I hate missions of mercy. So the dentists of the future create a collaborative learning and practice environment and be member of a healthcare team, permit a greater flexibility in the scope of practice. One way to deal with this is to change practice acts, but legislative methods take a long time, and I prefer the educational route myself. The dentist of the future will permit more efficient practice environment, focus on managing oral and general health rather than only dental disease, and to use the term that Hal Slavkin, former director of the NIDCR, used, it should be ophthalmology, not optometry. Science and practice and practical science. I don't like the term oral physician, but it's the area that we've settled on. But what should that person be? So at our school, we went through a whole series of strategic planning every 5 years, and we added to our mission of producing leaders dedicated to improving oral health by integrating dentistry and medicine. Our curriculum has the dental students with the medical students, you know that, for the first year and a half or so. And so they learn a lot of this, and they apply it, even though they may become orthodontists or periodontists or general dentists, although most of our graduates don't go directly off into practice. And our vision is to remove the distinction between oral and systemic disease. When we started this initiative, we wrote a paper, Dr. Reedy's in the office, in the New England Journal of Medicine that called for two things. All health insurance policies, whether provided through Medicare, Medicaid, or private insurance companies, could include coverage for dental care services regardless of an enrollee's age, and to integrate general medical and dental care in both practice and workforce education. Now, I'm not sure I'm going to give this to the Republican-led Congress right now. I don't think it would go very far, but nevertheless, this is the long-term goal. One way to do this is the growth of interprofessional education, and this has been an important part of dental education at many dental schools. Most of them are not as fortunate as us to have a direct relationship with the medical school and faculty of medicine. But in this paper that reviewed about 10 programs of interprofessional education done at various dental schools, we suggested that we change the conversation from oral health is connected to systemic health toward oral health is integral to overall health. And as an example, I just ask you to consider sleep apnea. Sleep apnea, that requires a lot of testing and all sorts of things, is something that more dentists get involved in than dentists who take blood pressure or check up on a hemoglobin A1C for a patient they might suspect of diabetes. And the reason for that is there's incentive to do that because they can make appliances that will be reimbursed. And so, in fact, a lot of care of underserved communities and a lot of care for medical dental integration requires some change in payment schemes. So we need to change the culture in dentistry away from the what, procedure-oriented, to why. And of course, in dentistry, the way we handle most real problems is we make it an accreditation standard, and therefore schools at least say they have to do it, which I don't agree with, but in any case. So what are the factors that make these efforts relevant? Well, I think there's a lot of new science. There's now medical treatment of surgical disease. started with peptic ulcer, won 2 Australians a Nobel Prize. But even for dental decay, there are now medical treatments to prevent caries that doesn't require the use of a drill, believe it or not. And I think this will improve. In addition, we have an aging population, along with Asia. There also is a huge primary care shortage, and integration of oral health into primary care is not intended to displace dental care, but to expand the workforce. You've heard Cass talk about workforce, and that's very important. Similarly, expanding the scope of a dentist to help diagnose and manage chronic disease would also expand the workforce. In fact, there are almost 20 million patients who see a dentist during a year who never see a physician. And so there's a real place for this. Oral health integration, at best, would include an electronic health record that could integrate the care, but I don't think it's necessarily the first thing that we need. And having switched to Epic at Mass General Hospital in the past year and a half, I would say that integrated care requires a good thinking doctor who takes a good history and examines the patient more than an electronic health record. It's a culture change. So what we've done is we've formed this initiative for integration, and I'll tell you about the members' goals and programs. We've had a curricula change, and I think you're probably going to talk about some of that, Ilsung, I bet. No? And that is to say the medical school and dental school, the curriculum now includes a primary care medical practice in the dental school, believe it or not. Dr. Swan is involved and runs the oral physician general practice dental residency at the Cambridge Health Alliance. We have a program from Northeastern where nurse practitioners and students, supported by a HRSA grant, come into the school and manage chronic diseases of the existing dental patients that the students have in school. Dr. Reedy and others have received a 5-year HRSA grant that was recommended by the Primary Care Collaborative that Dr. Evans used to chair. Do you still chair it? No. Well, you should have stayed chairing it. Forming collaboration with the Harvard Center for Primary Care, UMass Family Medicine, the Mass College of Pharmacy, and Allied Health Northeastern. And we're also developing with the Center for Primary Care what we call a practice of the future that would integrate medicine, oral health, optical, gynecology for a practice in the Longwood area. And so this is what greets patients, this vision of a teaching practice that incorporates primary care clinical experience, and that's been quite successful. And this is the brochure of the initiative, and this just shows you the membership that includes Aetna and Blue Cross Blue Shield. It includes DentaQuest, Dr. Ralph Ficillo's over there, Henry Schein, Philips Oral Care, lots of people. We just had a meeting last week. And in fact, this has sponsored 2 forums and a number of other things. So it has both educational components and clinical practice components and outcomes analysis and policy, and there are the forums, and we've held 2, one in October 2014 and one just this past November. This is the Foundational Continuity Clinic where the students learn primary care medicine. Medical, dental, pharmacy students together go in Crimson Care collaboratives. The Center for Integration of Primary Care is the grant that Dr. Reedy runs in oral health. And we have a number of collaborators, Northeastern. We're collaborating with CareMore, which is a program that's just adding oral health to a program for the elderly. And this has been quite successful. So the new pathways for this includes oral health and primary care. Nurse practitioners can do it, and in fact, DentaQuest has a wonderful web-based program called Smiles for Life that can teach you everything you want to be and do for oral health, but it won't get you licensed as a dentist. Physician assistants, but both nurse practitioners and physician assistants tend to go off into specialties. Primary care is still almost as much as oral health, the stepchild. Dentists, chronic disease management, and dental practice, they can change their scope of practice, and I think one day, with or without the change in the Dental Practice Acts, this will happen. And the other thing that we've been exploring with the medical school and the Cambridge Health Alliance and others is development of a dual degree program that would combine a dental residency in general dentistry with family medicine or primary care, which is modeled after the program that I know very well, which was a oral and maxillofacial surgery, MD general surgery program. And these are the things that we're working for. There's been a lot of work at our last forum. Dr. Lipton presented this, Medicaid benefit expansions in effect. And in fact, it found that coverage of adult dental benefits improved care and utilization. And this is the Medicaid expansion. 32 states had adopted it. It remains to be seen what's going to happen with it. But again, a lot of dentists don't participate in this because the reimbursement is so low. So we really have to think of other ways of payment, either getting away from the fee-for-service system with capitation or bundled payments in some way. But there clearly is a positive association between coverage and utilization of dental services, and that may be the most important thing. I'm going to skip this because you can't see it well. But at one of our forums, Clay Christensen, who's at the business school and the creator of the disruptive innovation theory, suggested that when he had to go get his wife a present of a technical variety, he used to go to Best Buy. When he had to get something to work around the house, he'd go to Home Depot. But now he can go to a Walmart and do both of those things together. When he wanted a snack, he'd go to a 7-Eleven. When he needed gas for his car, he'd go to a gas station. But now, even though Hess has changed their name, he can go to one place and get both gas and a snack. And therefore, he suggested that maybe the time has come for a combination of a dentist-physician who could alleviate the primary care shortage. This is just a series of books that's important in dental education. This was an Institute of Medicine study from 1995 that recommended, like the Guy's report, that dentistry stay within medicine, although this recommended separation. You notice purple and lavender and green, the academic colors of medicine and dentistry highlighted this. That's Professor Christensen's book, The Innovator's Dilemma. And what we need is something that's as useful as this. You know how you have to rip apart cookie packages to get to the cookies? Well, look at this innovation. A little tab here, you lift it right up and you get right to the cookies. That's what we need to do for integrating oral health and primary care medicine. And as I said to the group in Providence yesterday, the last performances of Ringling Brothers Circus were in Providence this week. The circus is going away. And so what we need is what's called the Blue Ocean Strategy. And guess what was the Blue Ocean Strategy for the circus? Cirque du Soleil. Cirque du Soleil is not going away, but Ringling Brothers is. So that's the way we think, and that's what we need to do. Oral health was highlighted in the Health Affairs Journal in December. So we're making some inroads. The medical dental divide, all sorts of things. Scope of practice, very important. And I'll just end with this. My favorite quote, Louis Manan wrote The Marketplace of Ideas, which is about the university. And he said, the key to reform of almost any kind in higher education lies not in the way that knowledge is produced. It lies in the way that the producers of knowledge are produced. And that's why we have the kind of curriculum that we do. And that's why interprofessional education will eventually move to interprofessional practice. Drew Faustus said universities must be accountable to the future. And I say so must dental schools and the profession. And I'd add that healthcare must be affordable, evidence-based, patient-centered, and equitable. And that's what your conference is about. So thank you very much.
So I'm really happy to be speaking here today. My name is Iyang. I'm a pediatrician at Boston Children's Hospital. And just out of curiosity, how many clinicians or physicians do we have here? So majority, okay. All right, so thanks for being here. I'm just going to very briefly highlight what we're doing at Boston Children's Hospital, and perhaps along the way share some stories about where we got to where we are and how I became interested in children's oral health. So I'll start by sharing a story. I was in clinic 2 days ago in urgent care, and I saw a 10-year-old boy who came in with complaints of pain in his mouth. So he came into the room and he told me he had pain in the left upper and lower quadrants of his mouth. And he hadn't slept in 2 days. He had had lots of difficulty eating and really was in lots of distress. I was able to check the chart because at Children's we have access to the dental chart. He had been diagnosed with caries about a year ago and had not followed up for care. And so I tried to, in my own little way, diagnose what was going on. He had lots of pain. It was really hard to isolate the tooth that was causing the pain. And so with my limited knowledge of dentistry, I thought it looked like he had an abscess. And so I thought, well, what I'd do is prescribe some antibiotics and then reach out to the dentist. But then I thought, why don't I reach out to the dentist now and see what they recommend that I do? So I picked up the phone and I called the dentist and I said, hey, I have a boy in my office and he has pain and I think it's an abscess. So I recommend that I can give him penicillin for 10 days and then have him follow up with you in a couple weeks. And he said, why don't I see if we can see him today? So he checked the schedule and said, actually, we can see him now. Why don't you have him come over? So I walked the mother over to the elevator. She went over to dentistry. They evaluated him, did some x-rays, and found out that it wasn't actually an abscess, it was pulpitis. And he didn't need antibiotics, he needed restorative care in the OR. And so I think that story really highlights how integrated care works. That experience was no different than if I had called the cardiologist or called any other specialty in the hospital. I was able to interact with them in real time and avoid giving him unnecessary antibiotics. He did not need antibiotics. He needed to see a dentist. And within an hour, he was in the dental chair. So I will, nothing to declare, very quickly outline what I hope to cover in my talk today. The goal is really to highlight what we're doing at Children's. There's a lot going on in the Longwood area, so I won't talk about what we're doing in the dental school. But there's quite a bit going on at Boston Children's Hospital. But before I highlight that, I'd like to take a step back and give a bit of a context for the physicians in the room that may not be as aware of what has been going on in the oral health arena for the last few years. So very briefly, I'll talk about early childhood caries, which is an infectious, transmissible chronic disease, which is really prevalent. Over the last several decades, the incidence has been increasing in the very young kids, so ages 2 to 4 years. And the consequences of caries is really, really far-reaching, so can cause pain, like the child I saw in the clinic a couple days ago. Millions of hours of lost school time. The parents have to take time off of work to take care of the children, and the financial implications are really, really broad and far-reaching. Caries is preventable. It's preventable if you start early and changing behaviors, for example, diet, the dental hygiene practices, and also through fluoride. Fluoride through the water or fluoride that can be applied topically. So in the figure, you see a picture of fluoride varnish being applied to the tooth. So it's typically 5% sodium fluoride. It has been used for years in Europe and just recently was approved maybe in the late 90s in the United States. And so fluoride was used by the dentist initially to prevent and arrest. It actually arrests and can actually reverse early childhood caries. The issue was there were not enough dentists to go around. The prevalence of early childhood caries in the younger age group was increasing, and no matter how quickly the dentists were working, there weren't just enough dentists to go around. And so they identified a gap that they felt that the pediatricians could bridge. There's a study that said that infants and kids age 1, about 85% of them will see a pediatrician, and only about 1.5% of them will see a dentist. And so the volume of providers the burden was on the pediatric side, and so there were opportunities for us to bridge the gap. The challenges, though, was that we were not trained. In medical school or in residency, we received very minimal number of hours of training in oral health. I know my story, when I was in medical school, I got absolutely no exposure to dentistry. I was interested in dentistry because my sister was a dentist, but beyond that, I had really limited exposure. And so when I finished residency and I went to work in Chicago, I did residency in Chicago, and I worked in Lawndale, an inner city community in Chicago. I, as every other physician would do, when I asked a child to open their mouth, my eye view went directly to the tonsils, ignoring the fact that they had teeth. I barely knew how many teeth a human being would have. But over and over and over, as I would focus on the tonsils in the peripheral view, I would notice in the population I was serving, the burden of disease was just really significant. And I began to ask myself, why? Why in this population of low-income minority children was oral health so rampant? And something else I noticed was that it was under-prioritized. Many of the kids had lived with such poor oral health for so long. It had become normal. They had pain, they lived with the pain, and it was just the way life was. It was under-prioritized by us physicians. We saw it, we recognized it was a problem, but maybe more important things like asthma and obesity took our attention, and oral health, took the back seat. And so I began to have conversations with my colleagues to really figure out what we as pediatricians could do to help bridge the gap. So the American Academy of Pediatrics has really been at the forefront in really trying to engage the primary care providers in being more proactive in delivering oral health, preventive oral health services. And so the goals, their goals are to promote oral health care in primary pediatric settings, to educate and advocate for primary pediatric care professionals to apply fluoride varnish, and to educate policymakers and payers about the importance of reimbursement for pediatric oral health care. And so it was actually a state-by-state effort, this advocacy of getting reimbursement for the physicians, because they felt that once physicians were reimbursed, by all means, they would begin to deliver the services in their medical settings. And so that the states at the forefront were Washington and North Carolina, and they were way ahead of the curve. But many people were kind of like, flagging in the background. And so what exactly is preventive oral health in a medical setting? So it's multifold. It's oral health assessments, doing clinical exams of the child's mouth, assessing the caregiver's oral health status. It includes anticipatory guidance and counseling about making dietary changes, early referral to a dental home. It also includes fluoride administration and supplementation, as well as interprofessional collaboration. At that point, we all know about the silos that exist. The dental world is a completely, separate world. We have no means of communicating with each other. And also at that time, we were typically asking parents to take their kids to see the dentist at age 3. But by age 3 it was too late. Many of them had already developed rampant caries by that point. And so here in Massachusetts, bring it a little closer home, in 2005, it was not a unique story. This was the same story in every other state. In Massachusetts in 2005, less than 30% of kids on Medicaid would see a dentist a year. A very small percentage of dentists, less than 12%, were willing to see kids on Medicaid. And so this led to a lawsuit by an organization, Healthcare for All versus the state. And the judge ruled in favor of the organization, and as part of the remediation plan, required the states to begin to reimburse medical providers to deliver fluoride varnish. The new policy was implemented in October of 2008, and as part of the reimbursement, the physicians will be reimbursed $26 per application of fluoride varnish. A year after the policy had been implemented, we conducted a study of physicians in the states, really to get an understanding of what the awareness of the policy was, their attitudes towards it, and what the barriers and facilitators were of fluoride varnish delivery in the medical settings. We found that 2/3 of physicians weren't even aware. Only about 5% of them were actually giving fluoride varnish, and there were multiple barriers that were identified: lack of time, lack of knowledge, lack of skill. Many of them said, you know what, I'm a physician, I'm not a dentist, this is not within my purview, go to see the dentist. And so we realized that simply reimbursing a physician was not enough. You had to actually use a more thoughtful, systematic approach to address the barriers in order to really fully integrate oral health and primary care. And so here at Longwood, at Boston Children's Hospital, we began the program in 2011. It was initially a pilot program within a quality improvement framework. initially it was just one medical provider and 2 nurses. And we had a grant, I think it was from DentaQuest initially. And initially it was a grant to just target high-risk kids of a certain age. And the key pieces of the pilot program was it was very physician-centric. So the physician was going to do the assessment, do the education, and then the nurse would provide the fluoride varnish while giving the immunizations. And then at the end, physicians would give them a toothbrush and say, you need to see your dentist at age 1. So we marketed it very aggressively, and we knew it was going to be a brilliant idea. And a year after, we found out that only about 120 kids were getting fluoride varnish each month. Now, this is in a practice with 19,000 patients, with 43,000 visits. So this is like really nothing. And so we took a step back and realized that we needed a more systematic approach to really address the issues that were being encountered. And this is really a picture of their multiple PDSA cycles that have been in the works over the years to really try to get to the root of what the issues were. And so as it stands currently, it's a more systematized approach that involves the nurse, the physician, and also the EMR. So for example, the child is placed in the room by the medical assistant. The nurse comes into the room and does an assessment of the child, asks the mother questions, what is your child drinking, etc. And then based on the child's risk, provides tailored education for the parents as to things that she can do to optimize the child's health. Talks about dental hygiene, etc., etc. The assessment was originally done on paper, but over time they recognized that it was good to leverage the EMR technology to help generate flags, etc. And so it's now done electronically, and at the end, the nurse is able to check off a box if the child does not have a dental home. And once that box is checked off, it generates an automated referral to dentistry. So dentistry can now reach out to the mother, to the parents, and schedule the child to see the dentist. Like I had said, initially it was very, very physician-centric at the beginning. And so some physicians really bought into the idea, and maybe others not as much. And so initially the amount of kids that were getting the fluoride varnish would vary. And so over time, they've really tweaked the program such that now the nurse, when she does the assessment, the provider goes in, sees the patient, does everything. The nurse goes back and actually provides the fluoride varnish and routes the order to the physician, so the physician doesn't even have to do anything. And so that really saw an uptick in the number of kids that were getting the fluoride varnish. The issue now came with billing. If you're not being reimbursed, it's unlikely that it's going to be sustained. And so we use a paper billing system, and we found that even though fluoride varnish was being delivered, not everybody was billing. And so they asked the physicians what was going on, and they said, well, the fluoride varnish is in an obscure place in the paper, and if I can't see it, I'm not checking it off, and I don't care. And so they reformatted the bill to bring that close to where the immunizations are, something that they do all the time. And so once they check everything off, they check the fluoride varnish as well. And that saw an uptick in the billing, but then even that had plateaued after a while. And so eventually they reformatted the system such that the nurse now actually proposes the bill for the immunizations and the fluoride varnish all together, and that way there's been an uptick in the number of kids receiving the fluoride varnish. I share that to say basically it has to be very intentional. It's not just something that happens. It has to be a very systematic approach to that. It's within a quality improvement framework that really makes it a high priority in the parents' care setting. So just a couple measures that over time, the fluoride varnish billing completed during Well Child Visit when it first started was about 10%, and then the changes that were made over time with the flags and reminders saw a little bit of an uptick. They relocated where the fluoride varnish line was in the billing sheet, there was a little bit of an uptick, and finally when the nurses started billing themselves, it actually took off much better. In terms of the assessment, so we're not currently looking at clinical outcomes, but they're looking at intermediate outcomes in terms of behavior changes. Through the risk assessment tools, they're able to look longitudinally to patients' behaviors, and they're actually seeing that over time, parents are actually making better decisions on behalf of their children. And lastly, I'll talk very briefly about the interprofessional collaborative practice. So like I said, there's dental referrals that are automated. We have a shared electronic record, and so each one has access to each other's notes. There's cross-pollination, whereby the dental residents spend time in the medical setting and vice versa.
in the waiting room, the dental students spend time educating parents about oral health. And also there's ongoing training for the residents, the nurses, etc. Because this is something that has to remain top priority. So keeping it at the top of everybody's mind. And so in conclusion, I'd say that integrated care really, the impact of integrated care has the potential really to increase access. We currently don't have data at our center, but the group at UNC has published loads of data that show that it actually does improve access to preventive dental care when it's delivered in a medical setting. It improves the quality of care. I shared the anecdotal story of my patient, and I saw that when I've gotten needless antibiotics and it was directed to get timely and quality care. The parents love it. Many parents actually look forward to receiving it and have actually really embraced the notion of integrating oral health and primary care. And in terms of clinical outcomes as well, we currently don't have data, but at University of North Carolina, they have also documented decreased prevalence of dental caries for kids that receive care in the medical settings. For those physicians that may not know the story of this young boy who died many years ago as a result of a subdural empyema. He had a untreated dental abscess that eventually spread to the brain. He had a pediatrician. He had Medicaid, but it was hard for the mother to find a dentist willing to take care of him. And so he got care a little too late and lost his life as a result. And Mary Otto, who Bruce had referred to earlier, had titled this piece in the Washington Post "For Want of a Dentist." But as I was thinking about it in terms of the health equity framework, I'd actually argue that it really was not, at its root, at its core, you could say, well, maybe it was the dental care, but I think at its core was the lack of an integrated health home. Where we have this notion that we are used to of all these silos that supposedly provide care. But if we think of this in terms of an integrated health home that is made up of a group of providers that are able to surround and support a child and their family and deliver care that is high quality and timely, right? Such that what if when he was 1 year old, he had a pediatrician that had been trained and empowered to provide fluoride management so that he didn't develop caries in the first place? What if when he was 11 years old, he came in for his well child visit and his pediatrician was able to look in the mouth and see he had rampant caries and pick up the phone like I did the other day and call the dentist and say, hey, there's this child that needs dental care, would you be willing to see him? What if there was a social worker in the group, in the home, that would help the mother navigate the complex Medicaid system as she had difficulty navigating and thereby speed up his access to care? And so in this notion of health equity that we're talking about this evening, we know there's the pictogram shows this shorter person who is unable to look across the fence at the game because of just the cards that he was dealt. But I see the boxes on the right-hand side as the integrated health home that perhaps gives a family, gives a population a leg up so that they are able to enjoy the game as well. I'll end there.
To save paper and try and do what I think a lot of you younger folks do is read off of the screen. I'll tell you the story about being in this room a few years ago, and it was, I think, the kindness of Dr. Donoff asking me to participate in, this was before we had the initiative at Harvard, to integrate medicine and dentistry, but it was the Center for Primary Care was having an innovation summit, which Jane Garber was here as well. Sorry for all this noise. I'm not as good at this. Next time it'll be paper. And the group was a room about this, this size audience, and I was on a panel, if you might remember, and it was on innovation. So I'm supposed to talk about dental, medical, and the other three panelists were these innovation gurus from these big think tank places, and they were all talking about how to design the suite so that the doctor can turn this way to the patient and still look like they're paying attention by typing on the same side. So I thought, what am I going to say about innovation and construction? So the only thing I could think of was, I have an innovation and design problem, which is try to get the mouth back in the body. And I think that qualified me for at least a 10-minute talk. So Today I feel a little bit like that because I think I'm the only non-clinician on the panel. And as I speak to you about the things I'm going to say, I do want to say I'm glad I didn't bring slides because they would have been repetitive. I am humbled to have been on this journey that, except for the Surgeon General's report and call to action that came before my hiring as the president of the Denticos Foundation, I've been on this journey as I think a very humbled observant and participant where possible from a different perspective. And I want to talk a little bit about that with you today. And I want to start by saying that about a month ago I was privileged to be on a panel in Melbourne, Australia. And it was the first oral health session at the World Congress of Public Health Associations, their 17th conference, our first oral health panel. And maybe some of you have been there and witnessed this, but I hadn't. And being a little bit anxious in front of a very large audience in unfamiliar parts, I started to realize that one session after another in the conference, and then certainly ours, began with a thank you. And maybe some of you know what I'm about to say. So at every opening of a session of public note, whether educational or civic, there is a thank you to the original owners of the land. And so the Wurundjeri, I hope I'm saying that right, people who were the people of Victoria, and where Melbourne is, are thanked. And so you're standing, we're conducting this session on the people who were here before in this U.S., probably the first wave we talked about. And so First Nation people are honored, and First Nation people are credited with many things. And the thank you is almost as common as we say the Pledge of Allegiance at our civic events. So that touched me very deeply because I think about the work that you're all doing, and I think we've tried to do together, as racing so far past that. And the urge, for instance, for cultural competency, I think some of our colleagues have reminded us that it's really about cultural humility. And the humility that we don't take time to express when we're thinking about how to solve problems that actually go from when the original owners of the land had to change their lifestyle. So for instance, if we were doing that practice here, I would be saying thank you to the Shamet and the Mystic and the Natick and the Nipmuc Wampanoags and others to say thank you for the origins on which we now get to stand and do hopefully flourishing work, but not forget where we started. That was coupled just by a month or so before that by being in Santa Fe, New Mexico as part of a Rhodes Scholar, not R-O-A-D, not the other Rhodes, I'm not that smart, Rhodes Scholar program, which was a lecture on Native American cuisine in the U.S. And Eurocentric dominant thinking had me thinking that tomatoes were from Italy and that potatoes were from Ireland. And I didn't realize that until the first wave around 1492, those European folks had none of that. And we here on this earth, in this part of the earth, were home to that. Followed by the awareness that as we take that humility to thank the original people who were here, that only 500 people were left after smallpox from European traders infected this part of the country, and so many people died. So the very origins of this country, in the way that it's currently constructed, and now with all the political angst and emotional angst that people are experiencing in terms of the way we govern, have a lot to do with the problems we're facing. And it's particularly true in healthcare. I don't need to emphasize that, I don't think, in terms of what we've heard about in terms of replace and repeal, but it's those structures and especially the social construction that I want to talk about today. So it's a little different than what you've heard, but I want to ground it in the fact that having lived through all of these experiences with the folks that you've just heard from has been very rewarding and very enlightening. So part of what this says to me about the history that I just talked about is that I had to give a talk at ADEA, which was the American Dental Education Association back in March, and the topic was oral health and social justice. So I want to say that from an esteemed organization like ADEA to allow a session on oral health and social justice, progress is being made. And so as I talk about this, perhaps the pieces will all fit to you. In preparation for that talk, I looked through some of the people that we should look to for doing good in the world of health, especially clinicians. So, our current day Paul Farmer, we think about what Dr. Farmer has done to address HIV and other diseases in poverty stricken areas. I think of, even like Don Berwick, who has stepped out of his sort of clinical role to think about being a policy person, introducing an idea like the triple aim, which is getting us into a construct where we can start to think about balance. And I think about Dr. Tim Johnson, who was on, who was a good friend and as a clinician, got to the airwaves and for years, for decades, has been educating the lay public, but is also a minister and has dedicated a lot of his time to feeding the hungry and to being active in his community. 25 years ago, many of you will remember that we had an incredibly hurtful and painful experience of violence among our urban areas, and especially the loss of a number of too many African-American young males. And Deborah Croslow-Stith was able to help us see violence as a public health problem. Dr. Gloria White Hammond, who is, as a pediatrician and a pastor, also able to step out of her comfort zone to be attentive to human rights needs in Darfur. And of course, I want to include Joan Reed in this because I think she brought justice and balance, not only to medical education, but to all of our careers, right? Agree with that? Yeah. So as I think of those folks, I didn't mean to leave out dentistry, actually, when I created that list. But since Dr. Donoff put how much he hates missions of mercy, I want to say that there's a dentist in Virginia who's sort of the godfather of that, Terry Dickinson, and I've actually talked with him about the fact that these lineups of where I volunteered and as a non-clinician, I had to bring those thousands of people from the line to triage, and thinking to him, Terry, is this really how dentistry should be delivered in the U.S.? That was 2009 when I did my first volunteer activities at Missions of Mercy, and calling to action. And there are a lot of good dental folks who are doing. Dr. Larry Coffey does donated dental services. There's all this effort around trying to fill in the gaps. And one of the things that I think we have to learn, which I did, it was 6 months into my job when Diamante died. I started in August of 2006, and February 25th, 2007, Diamante died. And Mary Otto had that in the paper around that time, fortunately. And it really made me question the fact of leading a philanthropic entity like the DentaQuest Foundation, where we were giving grants on that, doing good side, like we were giving money to build clinics and to support Dr. Dickinson and other dentists who want to do Missions of Mercy. And within a year, the machines break down in clinics and they come back for another grant. Or there's another 2,000 people in line. Or there's another great dentist with an idea or a clinician with an idea. It becomes, I hope you hear what I'm saying, unsustainable. And so we need to look for some other ways of deciding between short-term charity work and long-term sustainable justice work. And perhaps you've heard that comparison before between acts of justice and acts of charity, and trying not to make value judgments about the fact that one is better than the other, but trying to imagine that if we continue to do only good works of charity, while they will mount up to value, that the longer-term solution for what we're talking about today, where there are so many structural components to change, we need to get on with that. And so one of the things that I remembered was early on in my public health career, it was the time when HIV was not known, but a lot of people were dying. And so the journey of being first in a gay male identity with people who, in our own community, being gone from us very quickly and unknown why, moved into partnership that I was humbled to have the experience with a group of women, for instance, in a real estate office in Mattapan. Dr. Norman might remember this, the creation of the Women of Color AIDS Council, and then the Men of Color AIDS Council and the Multicultural AIDS Coalition. We started to understand that there was not the decision about now we know an infectious process that has to do with biology and human behavior, but that was laden with social strata, social isolation, judgment, moral turpitude, deserving. I can't help but think about that in the context of what I'm doing now in oral health. And while I have continued for 10 and a half years to try and help with the removal of social stigma around the condition of some of our mouths based on our backgrounds and some other things in the context of the current, and I will make the statement because it is so shocking, and I think we need to remember it in terms of what we're trying to do to integrate oral health in primary care, is when people make claims that good people, in other words, people who have lived good lives, shouldn't be paying for the health costs of people who've lived otherwise. The fact that that has been spoken in the past 7 days, it gives me a lot of charged activism, similar to when I feel like AIDS was first around and we didn't know what to do. So my comments today around oral health and social justice have to do with the fact that there needs to be an urgency that we're relating to in terms of where oral health will fit in a systemic change model. And so what I asked our staff to do 8 years ago while we were working with physicians and dentists in an interprofessional initiative was to say, are there constructs around us that we could point to actually invest in and engage people in to start looking at a brighter future? And those 4 systems that we chose were systems of care, financing, policy, and community. And when if I did bring a slide, it would be sort of a clover leaf of overlap of those 4 systems, and to do an analysis of where are those systems now and where should they be if we're looking toward a state of ideal oral health. And so I wanted to use one simple example from that. So in our care system, we identified that care, dental care, should be based on evidence, prevention, disease management outcomes. Now for physicians in the room, that sounds very familiar, right? It's not what happens in dental care. We haven't got to that point of being clear about evidence, prevention, disease management, and outcomes, even while we know some things. The other thing that happens when I talk to dentists about this is they say, well, if you, DentaQuest, by the way, would pay for evidence, prevention, disease management, and outcomes, we would do that. Now my challenge is, who's going to go first? Because somewhere that systemic change needs to be looked at and understand that you can't do one without the other. So that is where, as previous speakers have talked about, systemic change comes about. We have to think not only of those 2 systems coming together, but also oral health literacy. And the connection between oral health literacy, as is health literacy, is that the educational systems aren't geared toward the empowerment of communities who are burdened with the greater burden of disease to be able to be empowered into their own system of care. So one of the other connections to Clay Christensen that Dr. Donat mentioned is that in his Innovators prescription, maybe you've seen this, he actually talks about diabetes. And he says that if we were paying attention to innovations that we might progress, a diabetic person with diabetes spends about 2 hours a year with their clinician managing the disease and 8,758 hours on their own managing that same disease. The diabetes doesn't go away when they leave the 2 hours with the clinician. So they're managing that disease on their own all this time. So if we're going to look at prevention and evidence and disease management, we need to include all the parts, including the people that are coming to us for some support. I guess that, Bruce has mentioned the Smiles for Life curriculum, and there are very dedicated folks who have worked on that over the years. When I first saw Smiles for Life, I don't know if any of you remember, they used to have a screen that you'd put plastic sheets on and you draw on, and it would show on the screen. There was sort of overhead projectors, and that's how Smiles for Life was. And then it got onto somebody's PowerPoint, and now it's a web-based curriculum. And so, it's got 8 modules, almost 9, because we're now including a model for community health workers, a module for community health workers. When we first started, there was no module for geriatrics. So I think the tools are coming along. The spirit of collaboration between pediatricians and dentists and family medicine and physician assistant and nurses. And the missing part in many of those things is the people who we're in touch with. And I think that medicine, public health and medicine, I remember going to a meeting on the other side of the courtyard in the early 90s when we were talking about medicine and public health coming together. I think we're doing a better job in population health and individual health, but we haven't yet got to that place on oral health. So the advances are terrific. The one thing that I thought we might stop and talk about today in terms of this journey is what's happening in medical and dental education. And I did some background reading on what's going on in social justice education in the medical school curriculum and in the dental school curriculum. I found one really good example at Loyola where they've brought together their law department, their ethics folks, their medical folks, and their social work folks. And they actually have an integrated social work course. Now social work, when Dr. Mayor Lusadas was here for lunch, we were thinking, well, maybe social work should just take care of it all, right? I mean, they have 6 core values on which they base their social justice education. They talk about service, social justice, dignity and the worth of the person, the importance of human relationships, integrity, and competence. In medical education, we have seen some advances. There was a JAMA commentary a number of years ago and talked about 4 concepts of social justice education. Of course, beneficence, non-malevolence, sorry, that was a tricky one, respect for autonomy and justice. The dilemma, of course, in that continues to be structural because the economic model, the business model that we're using for medicine, what is the trade-off? Is there a trade-off between the financial impact and doing the right thing? And with the emergence, I think we've gone through a lot of the hatred periods of managed care earlier on, when there was some negotiation about who was deciding what about care, that there's still that pressure. I haven't found a lot of social justice training in dentistry or dental education. And I think it's getting to the time when we understand that we cannot do systemic change without thinking of whether we're living with unjust systems. And whether we, you, all of us together, are to become the agents of change that are required to have a more balanced and just arrangement for health care and overall health in this country. I think what I'd like to share with you in terms of the positive folks, the positive image of folks who are coming together, there's a network that we've been supporting out of the DentaQuest Foundation called the Oral Health 2020 Network. It is made of multiple stakeholders. It approaches it from a grass tops, grass middles, and grassroots perspective. In 6 states, 20 grassroots organizations that had nothing to do with oral health as far as they thought, because, for instance, the Tampa Bay Human Services Collaborative, they thought they were dealing with homelessness and hunger, and that's all they could, and housing and those kinds of things. But they revealed in their proposal is that oral health is often the #1 complaint that they meet people with when talking about how you feel. Do you have any health problems? My mouth hurts. But they never felt empowered or thought there was a connection between their housing and hunger and all those issues, workforce issues, and placement to oral health resources. So there's been a great breakthrough. Those 1,200 people who are in the Oral Health 2020 network, and they were in all 50 states, have made a claim that oral health is a social justice issue. So whether the structures and the systems around us have not embraced that, people have. You can count on at least 1,200 people in this country, and I hope some of you will join that, who are saying oral health is a social justice issue. So I'd like to just close with this idea. One of the things that came out of all the events that others have talked about, whether it was the IOM collaborations, the the U.S. National Oral Health Alliance in 2009, the ADA had an Access to Care Summit, was that we created the U.S. National Oral Health Alliance, and its mission was to find common ground on 6 top priorities that were really difficult. Medical-dental collaboration was one of those. And people came together, not in the format that we are now, where we're talking to you, but at tables, they talked about what they needed to do to reach unity. After one of those sessions, Dr. David Neumeister, who's a retired dentist from Vermont, sent me a book, and maybe you've heard of this book. The book is entitled The Righteous Mind, Why Good People Are Divided by Politics and Religion. I don't know if anyone's read it. I know that the term social justice sometimes conjures up morality or political views. I think there are a lot of good people in medicine and dentistry, in oral health, and in communities. I hope that the pathway forward, as we try just with medical and dental integration, does not allow us to become more divided as a people, but that the topic of social justice and other factors that have promoted division in the past, that we can turn the curve. You as fellows are doing tremendous things. I was so pleased to witness both the conversations last night and the presentations today, moving into this space around unity in the country, maybe through dental and medical integration, is a great step forward. I appreciate what you're doing, and thank you for giving me a few moments to share this with you.
I want to just take this moment and run through it. This is the second time I've followed Dean Donoff in a presentation of the last month, and we normally run out of time. But I also want to just take this moment to tell you all that Dean Donoff's birthday is today, so wish him happy birthday on the way out. We are celebrating 50 years of the dental school. I don't think there's any relationship between his birthday. But, you know, tonight, or at least this afternoon, we've talked a little bit about what are some of the implications and relative to what's the bigger picture. When we talk to medical people, we are not necessarily trying to sell you oral health. What we're trying to do is to help you understand that it should have been included in your education, in your core curriculum, but it was not. So you got cheated, because it doesn't take a super physician or anybody else to figure out that you should have learned about the oral cavity. It is connected to the body. A child can tell you that. So when we celebrate the few physicians who understand that, I mean, they're trying to heighten and enlighten you, but it's not rocket science. Some of the statistics that were named today are great statistics. Let me just give you a few more. 15 states in America, only 15 states of America have an oral health component in their public healthcare system. Only 15. 100 to 30 to somewhere like 160 million Americans have no dental insurance. Matter of fact, we don't even have dental insurance. We have a dental benefit that averages about $1,000 per year, which makes oral health the largest or the most expensive healthcare entity for out-of-pocket cost. 50% of dental costs are out-of-pocket. Medicare has no dental component. And there are several lobbyists that help block that, but one of them, unfortunately, includes the American Dental Association. The military in Desert Storms changed their concept of how they offer oral health care, because 35% of the non-battle casualties in Iraq were dental pain. 90% of all dentistry is private, only 4% plus is public. This is a global issue, and as you heard from the speakers today, dental disease is transferable. In other words, you can catch it, you can pass it on, vertically as well as horizontally. So what's the value of the mouth? And I think that's what we're trying to speak to you about here today, especially to physicians and other people in other healthcare entities who weren't fortunate enough to get oral health included into their curriculum. It has been researched that there's over 100 manifestations that can be attributed to the oral cavity or found in the oral cavity. Oral cancer is on the rise because HPV is on the rise, and oral sex has always been on the rise. Malnutrition, diabetes, pregnancy are all issues that we find that are related to disease in the oral cavity. And what is a mouth for? You know, we told you a few of those things, Dr. Evans did, but the mouth is also for other things, such as just to smile and taking a photo, to swallow, to chew, to breathe. It's an airway passage. To communicate, to spit, to open a bottle cap, to put on lipstick, to chew, to cry. The TMJ is related to your cervical chain and your spinal cord. To lick, to suck, to swallow, to kiss. And I contend that the oral cavity is probably used more than any other part of the body for sexual activity. What happens to our dental students when they go into school? They have a preconceived notion about what a dentist is. And that's usually reinforced because we think that a real dentist is a person who practices dentistry, usually in the private sector. Enough credit and not enough credit is given to those people who are administrators, who are professors, who are teaching, who are researchers. We need to change the perception. Students are coming in with high loans that sometimes makes them feel that they cannot go to work in areas that are not generating enough income. They don't necessarily choose the military, which would pay for your education just for 3 years of service, or the Indian Health Service or the National Health Corps. Usually the path is to go into the private sector to try to generate enough money. But those numbers of people who can actually afford the type of dentistry that we're being trained to do are dwindling. What are some of the other issues? Well, let me just tell you that it's also the responsibility of medical people to understand that you have to participate in making sure that what we're talking about here is more diversity in the healthcare sector. Oral health is just one example. Mental health and behavioral health is another. These areas are extremely valuable and important, but these are examples of the fact that we leave out. And it's up to us to be more innovative and creative and just using common sense to understand that you cannot afford to leave out any discipline that has to do with the mind, the human body, and the spirit. Jesus said in the quote from the Bible that a prophet can't get any respect in his hometown. I was at the Library of Congress as accountable care was being discussed. And the meeting there was the social determinants of health people, the sociologists, psychologists. And across town, the medical doctors were also having a meeting. And in this meeting at the Library of Congress, the people studying the social determinants of health were all bragging about that they're on the front line. That all that we do as clinicians is put Band-Aids on pre-existing problems. So I stood up and I identified myself as Dr. Brian Swan. I teach at the Harvard Dental School. And I asked the question that if you guys think you're so important and the medical people are meeting across town, they're saying how important they are, why don't you get together and work together to have more power and to come up with solutions? There was a long pause. I thought, did I say something wrong? And finally, the great David Williams, right here from our School of Public Health, said, we get it. We know that dentistry is important. I thought to myself, what the hell did that have to do with my question? So it took me 3 months to get a meeting with him in his office, and I talked to him about it. I said, you missed the point. And in that conversation, we began to understand that I needed to find a different way to identify myself. And shortly after that, I ran into a professor emeritus, Don Giddens, who was talking about this concept called the oral physician. And after those conversations, I decided to adopt that concept because it gave me a different mindset and a different way to introduce myself that would spur the conversation. So I am an oral physician. It's more than being a dentist, in my perception. And it is perception that we are talking about here. That oral health really should have been a subspecialty of medicine, and perhaps it will find its way back to that. But it shouldn't just be people in the dental profession who are making that argument. It should also include you. Because you can't sit back and ignore the fact that there is something that you missed in your education that is vital for you to know. And if we're all going to work together in this area of issuing and helping to move the agenda for primary care forward, we have to use everyone who has been trained in medicine, whether they're allied health people or not. to work together as teams to solve that problem. So in the GPR program, we are trying to work on this concept of saying that the oral physician is a person who is looking at comprehensive primary care in general, but specifically specializing in the oral cavity. We're looking at communication, not just IT communication, but we're looking at communication in terms of how you and I, as Dr. Ing Chang talked about, and communicating with the different disciplines. We're working not only with bringing primary care and family medicine, internal medicine people through our clinics, but we're also working, as you've heard, with nurses, and we have recently started to work with pharmacists. At the Black Caucus last year, I talked with a vice president from Walgreens, and he said that on average, a diabetic patient visits the pharmacist 20 times a year. So of course, my question was, what do your pharmacists know about the relationship between chronic inflammatory inflammation in the mouth and how that relates to diabetes? He says, we don't teach that. But what if you did? Because the pharmacists have branded themselves as an information center. So it's an opportunity. We have to look at building capacity. Some of my colleagues are here. We work together in Rwanda and work together in Haiti. Rwanda is a country that has 11 million people with 25 dentists and about 150 dental therapists. Haiti is a country that has 300 dentists for 4 million people. If we start training nurses, which is the largest workforce in just about any country, about the risk factors of oral disease, that is getting to the root of the problem by having someone in the office or in the clinic teaching primary care simultaneously with the doctor. And as you've heard from Dean Dunoff, we're also talking about how we have revamped the training so that not only do we have an examination lecture that takes place for all first year and medical and dental students who are all called medical students in the first year, but we also have integrated oral health into the medical interview. It has to be in the core curriculum before it's something that's really going to make a difference going forward. So what do we do next? I think that what we have to think about here is, first of all, dropping egos and get out of the concept of hierarchies among ourselves within our different disciplines. We don't have time for that. People are dying wherever we're talking and trying to figure out who's more important than the other. We need to work together as a team. We need to change curriculums. We need to all accept the responsibility because the models that we produce here eventually become global models. We need to emphasize primary care and prevention. We need to all know what are the most significant risk factors relative to where we work and live. And we need to also think about this diversity issue. We talk about policy and issues such as policy, but we need to also create policies for ourselves so that there is no demarcation between any and all of us as healthcare providers. As Mae Jamerson said at the American Dental Education Association, we want to get to the nearest star, is what she was talking about, which is 20 light years away. How can we get there with our current technology? We can't. So the challenge was, which creates an opportunity, is to think beyond what you know. What you know is limited, and we need to begin to think beyond that point. Because after all, whatever venue and environment that you're working in, you and I are the ones we've been waiting for. Thank you.
This year, the Reed Scholars created what we termed the Vision Award. As you know, many visionary people in our existence, including beginning with Joan Reed, the awesome Joan Reed. But in terms of the Reed Scholars, We wanted to recognize people based on a certain criteria. So we created the Vision Award in recognition of individuals and organizations who, through their extraordinary vision, have made a significant impact on the growth of our organization, made a meaningful contribution to support our ideals and mission, and have an unwavering commitment to health equity. And some of you may know, but probably most of you don't know, is that DentaQuest gave us our first seed money. They saw how valuable we were. So our first annual Vision Award goes to Ralph Facillo and DentaQuest.
It's a big surprise. Thank you. Okay. I'm not either. Well, thank you very much. Thank you so much.
You're very welcome.
Did you say? You know, I've known Dr. Reed for a long time. We've done a lot of things before I came to DentaQuest. But each time that I've been in the presence of those of you who have been scholars, it is so inspirational. There are so many things that you've said in the past 24 hours that have been meaningful. And over these many years, I think our first grant was really well spent. Thank you.
Hi, I'm Monica Lay. I'm a medical director for the primary care clinician plan here at Mass Health. I had a question. I really appreciated all of your talks. I had a question or comment for what you brought up, Mr. Facillo, about social justice and dental or oral health being a part of that. So I have a very close friend that works, is a clinical social worker, works at Project Place, which does job retraining, especially for a lot of women that are coming out of homelessness, have battled addiction, have survived through violence and multiple problems. Their job retraining program includes a 4-month stint where they're employed with a partner at Project Place, but then they're sort of trained around skills for interviewing and so forth. But once, imagine this individual, she went out to do all of these interviews, didn't get hired anywhere, and it was only when one employer basically said to her face, "I can't hire you, you have no teeth." You know, that really has knocked her down back and really plummeted her into a spiral that she hasn't really recovered from. So how do we, you know, as the clinician, as maybe their primary care doc, should they have started this, you know, we're all judged by the smile or the teeth that we do or do not have, and especially in the case of substance use or substance addiction issues. So should this have been caught earlier, you know, treated as maybe part of this job retraining program, and covered by whatever insurer they have at the time?
Well, maybe I can start by just commenting on the fact that, you know, I go to a lot of community events and I had a similar experience when introducing myself at one of these very nice affairs to someone who was a small business owner. And I happened to say I worked in oral health, and she could have been the person who said this to the woman you were talking about. Well, you'd never hire anyone without a good smile. And it struck me that this is the social stigma piece of oral disease. I mean, this is a disease concept that is, you know, left out a few of the comments. We're still looking at this as a cosmetic issue. We've been hardwired to think about this, and we have good colleagues at all the dental supply companies, but it's still about straight white teeth and, you know, being able to show up for the photographs with ways that people expect us to look. And so I think that social concept needs to change. And then I do think there's a place in the clinical pathways to begin to introduce the other values of evidentialism. In other words, there's something about that economic and social isolation, but then there's also something what's going on in the mouth relative to how long people are able to keep their teeth in what condition. And that's from a lay perspective.
I just want to add to that is that the state at one point cut out dental services, they brought them back. And one of the things they brought back were the ability to do anterior restorations, composite restorations, which is a tooth-colored filling, and also to do root canals and crowns on front teeth or anterior teeth. And the main premise for that is hireability, that you would at least have your front teeth that would give the appearance of a nice smile, which would make you more presentable and help you to get employment. So there was an emphasis placed on that. Now, the back teeth, no, they don't care so much about that. But that was the idea.
And so the policy issue that the Oral Health 2020 folks are working on, the national network, their third goal is to ensure that there's an adult coverage, not only for Medicaid, but also for Medicare. So after you're 65, there is no dental benefit in Medicare. There's a large group of national stakeholders working on that. But the Brandeis study that we funded showed two consequences of a lack of adult coverage in Medicaid. One is employability, and the other is propensity for opiate abuse. And so both of those have been proven in terms of a social return on investment of covering adults with Medicaid relative to whatever procedures are covered, but just the fact that there's a lack of adult coverage in most of the states in the U.S., we're still struggling with that very issue.
Just one more quick point to your question about could it have been prevented earlier. I think my talk focused on the pediatric population, but there's lots of opportunities throughout the life course to engage people. So for example, what about when she was pregnant? If she got pregnant, when she was receiving prenatal care, perhaps her OB/GYN could have talked to her about her oral health status, because the mother's oral health status impacts that of the child. And so as clinicians, there are multiple opportunities for us to engage with patients throughout the life course.
The only thing I'll say is that starts in a particular culture. And I remember the very first patient I saw as a resident, as an intern at Mass General Hospital, was a mother bringing in a child because the child was in pain, and her complaining about how he didn't sleep at night and complained all the time. And the answer to that was giving him a bottle that they could suck on and create caries. And losing teeth was the modus operandi of the time, and it doesn't have to be the case anymore. It doesn't have to be the case, and it's why what Ilsang said about getting kids seen early is important. And there have been great studies of this at Boston Children's Hospital, actually funded by DentaQuest, Man Wei Ing, and all over the country. It's been shown. It's a matter of putting your money where your mouth is.
Thank you very much for your presentation. I'm Tamara Brown. I'm a family physician, and I work for Ascension Health, so I'm in a large system. And I guess my question is about barriers regarding adoption and spread and true dissemination of these practices. I grew up in medicine, working in community health centers, 17 years, down the street from Lawndale, actually, in Miles Square. And back then, in the 90s, we talked about, integrative care, mental, oral. In Texas, we had a model where we actually had pediatric dentists having time in the pediatric clinic so that they can help establish that and have a visual imprinting with the pediatricians and primary care providers to do all these practices that you're talking about. But there's something that's missing from the translation of the academic, the policy, to actual implementation and spread. I would love to be able to take back, to our system as we're tackling disparities and social factors and all this and say, hey, these are what the oral physicians and other professionals are telling us we should be looking at as a system. But what is it? I wonder if you could comment more on that. You talked a little bit about payment, but I wonder if there's more of a barrier that we're not reaching or talking about out loud. Thank you.
So I can talk a little bit about the 9 years of working interprofessionally and what it took for each profession to find their own path in terms of how to think about working across the disciplines. And pediatricians, as was pointed out, is one of the first groups, I think, that were funded by NIH, HRSA actually, to develop an oral health focus that was described earlier. And it was only when the physicians, the family physicians, met the pediatricians and began a collaborative conversation about what dedication they each had to the oral health work that we were able to start to build. So in the first, just to give you an example, there were 8 people who met just outside of Seattle with us in 2008. And those included only the pediatricians and family physicians. The next year, we met in Evergreen, Colorado, and invited nursing. We invited physician assistants and an OBGYN physician from Western Massachusetts. The conversation was very much a building conversation, and eventually we added dentistry. Everyone had to find their own path. So I know it's a slow process, and that's why sometimes philanthropy can be helpful, because we have a long view. The systemic change model about payment and care within a frame of evidence prevention, disease management, and outcomes started to create a common language and familiar experiences from the medical world. And quite honestly, with all respect to the dentist, trying to figure out why dentistry would not come closer to or within the boundaries of payment and care models as medicine had adopted. And I think Dr. Donoff mentioned, and so did Dr. Swan, about some of the professional inertia, I call it, that is resistant to change. So I think we have some, this is all in that, there's a big bundle of stuff in the corporate world now around change management. This is a change management process along with the social, structural, and social justice images. So those are just some contributions from the experience of not being a clinician, but working across clinicians. I don't know if the clinicians want to talk about that.
Excuse me, from my perspective, I think it has to be a multi-pronged approach. I think oftentimes thinking about your system, that usually is a champion that takes it on and does not stop until it permeates the entire system. Usually you have to get buy-in and finding out what is important to the system. If it's reimbursement or financing, you can use that as a lever, because every state except Indiana reimburses physicians, and it actually makes sense to generate income that way. From a social justice perspective, the argument can be made. And I think in terms of the pipeline, they're also now in the medical schools and the residency programs, now training physicians to become more aware of the importance of oral health. And so I don't know that it's going to be one single approach, one single lever that's going to make a change, but using multiple pronged approaches and finding out what is important to the core mission of the health center where you work, I think that's how you're going to be able to make the argument for them to buy in.
I would just add one other thing, and that is that I think the culture of the applicants to dental schools, the education that they get, all foster an individual who's entering a healthcare profession, but also a small business. And although I think Brian's statistics may be a little off, there are much lower percentage of dentists in private practice. There's been growth of dental service organizations, but hospitals, which used to have in this area, every single Harvard teaching hospital had a dental service. Not anymore. There's only one left at Mass General Hospital, because there was more money to be made in cardiology than in dentistry. It was very simple for hospitals to make that decision. But the one thing that I think we haven't talked about today is a so-called dental therapist or mid-level provider. This is based upon the New Zealand dental nurse. They have them in Australia. It was started in Alaska. And just to show the cultural issues, when this started in Alaska, the American Dental Association sued Alaska for violation of the Dental Practice Act. And I remember we had the players here at an alumni day once, just so you understand how people think. In any case, the woman who, actually I did a case with her on this, interviewed 35 volunteers that the American Dental Association sent to Alaska. And the first thing they wanted to know was how much they were going to be paid to take care of the Eskimos. And she said, you know what volunteer means? And then they wanted to know how much cosmetic dentistry they were going to do. And she said, we're talking about Eskimos and Indians and tribal people who are out hunting seals and whales. They're not interested in cosmetics. They're interested in alleviation of their pain. But the thing that did it was, she said they're going to have to be credentialed at the local hospital. Dentists don't like to be credentialed, okay? Now, this sounds very harsh, but this is true. But I think mid-level providers, which have been designed to take care of underserved communities, can be used in a lot of different things. And it's kind of like a nurse practitioners. Now, I've been in the state legislature where nurse anesthetists yell at the anesthetist, and the anesthetist yell at the nurse, and the nurse practitioner yells at the physician. And surely some of this is going to happen, but they do make a difference. And as much as some of my friends don't like to be seen by the nurse practitioner and want to be seen by the physician, it makes the system work better. And I think dental therapists who could do some, regular restorative dental work could make a difference for a lot of the issues, particularly at the health centers, which I think is a great way to practice. You look in the New York Times today, there's a great op-ed piece on the medical system in Spain based on community health centers. Really a very nice piece. But that's not our mindset. And, tracing the history is too involved, but culture is important.
An OBGYN at Boston Medical Center, and I also am Assistant Dean for Diversity and Multicultural Affairs there. And I want to describe something that we're doing in caring for prenatal patients that involves introducing pediatric dental awareness as well as dental awareness for pregnant women. So I do centering in pregnancy. Centering in pregnancy is present in 6 of the, 16 health centers that are immediately in Boston, and also parenting centering is present. So this is a big deal because you have your patients for 2 hours. You're billing for a single visit, but since you're billing for 15 people in 2 hours, you don't have to worry about what can I talk about in 15 minutes. And you bring up different topics at different times. So I'm part of a pilot grant. I've had a dental resident or a dental student, I don't know what the right terminology is, but he's come to my centering group for 15 minutes for the last 3 times and educated these women who are between 16 and 28 weeks of pregnancy about their own dental care and about when they need to initiate care for their future children. And then he's surveying them. Now, we have a very small grant to do this, but if it's effective, we're going to do it in centering at all of the health centers that we service, because we do centering at Codman Square and Whittier Street and Harvard Street and Upham's Corner. But we're also going to bring it to parenting and centering, because we then have a bunch of brand new parents who have 2 hours. So we don't have somebody trying to bill in 15 minutes or 20 minutes or a 30-minute well-child visit for everything they need to cover, plus what they should have learned in medical school and never did. And it strikes me that between academic health centers and community health centers, you have the opportunity to reach the majority of the underserved population, given what we know about where those people are getting care, which is at the places that we're working. But I don't think we can make up for what we're not learning, and I would love to see me be able to provide all the care, but I would even more love to see me be able to partner with support at regularly scheduled intervals that are supported by my institution, but also by your institutions. Because I got to tell you, getting a dentist to come to the health center and talk to my prenatal patients is very hard. They don't want to come. And you all want to come because you are on the cutting edge of your thinking, but nobody else really does. We have a school. Academic health centers are an ideal way beyond the education of students, I think, to leverage your residents and your faculty in a altruistic manner. And I would be interested in what you think about institutionalizing programming. I think the Council on Teaching Hospitals through the AAMC would be a great place to start talking about building those bridges so that it's part of all teaching hospitals' obligation to their residents to provide partnerships at critical moments. So I don't know.
Just to make a comment to your comments. Using the group model is something that we heard about in medicine about 3 or 4 years ago. And at the Cambridge Health Alliance, we do group models as well. We do group models, or at least we have experimented with group models to increase new patient visits by teaching them and simultaneously bringing them into the fold, into our clinic. We've experimented with group models for pregnant families to bring them in as a group and using peer learning for them to discuss what issues they have around oral health, both for the pregnant mom but also for their newborn child. We've done group models historically for infants and toddlers using lap exams and fluoride varnishes and media programs that we can show them. And we've also been relatively successful with group models around making dentures, which is a little bit way out of the box. So our group model brings in 10 to 15 different denture patients, and we see them in a conference room. And we do all of their procedures relative to making the denture with the exception of the delivery. So we borrowed that model from medicine, and it works in terms of reducing the anxiety of the patient, especially denture patients who've already had the anxiety of having teeth extracted, but it also reduces the anxiety for the healthcare provider. And of course, the same way as you're doing, we can invite a medical person to come in to talk to our group denture people about diabetes or high blood pressure. We can invite a nutritionist to come in and talk to our group about how to masticate food when you are edentulous, what food preparation might be, how do you get vitality from the types of food that you're eating or not. And then we have the primary care physicians that have diabetic groups in Haitian Creole, in Spanish, English, and Portuguese. And our residents, who we have one here today, they are farmed out to go to those groups and use a curriculum, modifying it as they wish, that was actually created by Harvard students who got a grant from Harvard's Primary Care Center to develop a curriculum to interact oral health into diabetic groups. Now, most of the diabetic patients understood tooth decay to a bit, but they had no idea, for the most part, about how inflammation in the gum tissue, periodontal disease, impacts their diabetes. So this is a good concept, and I think that using dental students, using dental residents, is a good way to integrate oral health into your programs and making it part of these residents and student programs so that there will be sustainability. That can be done. Dentists won't leave their private practices to do that. Historically, most dentists will do dentistry with a heart. It's a program that was created through the American Dental Association, where you give a half a day to 1 day per year to do free dentistry. And then we also, it's very common for dentists to talk about the fact that I'll give back to my community when I retire. So we have to be able to change that perception of thinking to understand that we have to be involved in policy, we have to be involved in advocacy, and to build social capital in our community by leaving our offices and getting out into the community rather than expecting people with low oral health literacy to come to us. And we need to be able to do that on a continual basis.
Great. Well, thank you for your insightful comments today. I'm Luis Castellanos. I'm a cardiologist at UCSD, and working in an academic center, I can respect how important it is, oral health, when dealing with cardiovascular illnesses. One of the things I've noticed is that in the East Coast, there seems to be a greater amount of awareness in terms of the importance of oral health and how that relates to medicine in general. Yet when I'm at the West Coast, it seems to be a lot more separated. In fact, Brian may be better attuned at this, having gone to med school in San Francisco, but I don't see that type of connection between the two in the West Coast versus the East Coast. And I'm curious to see the difference of why that occurs, and why is there differences in thought and models, and how that may necessarily respect to perhaps other models and international models, as you mentioned, in other parts of the country or the world, in that matter, that could help change the shift, the mentality in terms of how we can bring both fields together. Thank you.
I'm surprised because I know California has gone through a lot of angst in the past year or so to take care of their underserved in terms of oral health. It's been a problem with money. But in San Diego, you're UC San Diego, there's a huge pre-dental club like 200 students. I've been out there a couple of times. A guy named Jack, I'll remember his name, who runs it. But there's no dental school. I think maybe just like UCSF and UCLA, and they need a dental school. Maybe Stanford needs a dental school. That would be a good academic place for a dental school. But I'm surprised at that, because there are a lot of very, very caring dentists who are concerned about that in California.
I mean, I can tell you that just when we have a patient who needs valvular surgery, just to actually get their teeth extracted before we can do the valvular surgery, we need to actually obtain dentists from the community to come into the hospital to have it done. It needs to be arranged weeks in advance.
So there's no oral surgery service, there's no dental service in the medical center, period.
Correct.
Wow.
And this is a teaching academic center where, again, the discrepancy, how you see it in the West Coast versus the East Coast is quite
So I'm a storyteller, so I'll tell you my favorite story about this. Howard Oakes was my dean of students here, and he used to recruit both for the medical school and the dental school. And that's why I came up to here to go to school. I grew up in Brooklyn, New York, and my mother only wanted me to stay in New York, and I didn't. Broke her heart. Howard Oakes was invited by medical school classmates who were at UC San Diego Medical Center to come out and help them start a dental school. This is in the late 60s. He flew to Los Angeles, went to rent a car, and he was rather absent-minded. His driver's license had expired, so he never was able to go to San Diego. He started the dental school at Stony Brook instead. So that's why it happened.
On the East Coast, there seems to be, we've always said that there's greater emphasis on the medicine aspect of oral health. And on the West Coast, of course, if you live in California in particular, San Diego, LA, it's Hollywood. The focus is on cosmetics. People don't even want to talk about, we don't even have cemeteries in the West Coast. So it's just the fact that the emphasis is placed a lot more so. You take UCSF, which is one of the top dental schools. It used to be that you had to take a performance test to get into UCSF. In other words, you could have a 4.0 plus. You could score the highest score possible on the DAT, entrance exam. But they had a performance test, which was all day from 9 to 5 o'clock in the evening, where you had to prove that you could use your hands by sculpturing a tooth out of clay and carving a three-dimensional figure into a piece of chalk, among other tests. You fail that, you didn't get in. So the emphasis has been on the cosmetics, in a society of California where everybody, no one wants to get old.
That's true in general. The emphasis is on the what and the procedures rather than the why. And part of that, in case you don't know it, is when dentists graduate and get their degree, to be licensed now with regional exams, they take an exam that has them bring in live patients to do procedures. Atrocious, as far as, be like a cardiac surgeon bringing in a patient and doing a cabbage in front of 4 senior surgeons, okay? To its credit, the American Dental Association is now moving towards an OSCE, not without huge fights. It'll probably be another 50 years. But that's why that happens, rather than think about it.
Not to interrupt, great conversation,
sorry.
but we're a little over time.
Oh.
Anita, I will let you ask your question, and then we're going to close out the session. But you can give one question, one answer, and then we're going to close.
Wow, this is the first time in history I had a long story like everybody else before my question.
Oh.
But and I had an excellent story too, Mary. Okay.
Oh, let's
but I'm
hear
just going to jump to.
We'll have a few more times
Okay.
for informal discussion.
I'm gonna
afterwards,
jump
but we
to
need
the
shut
question
down
then.
The formal question.
But I was going to pull in the exhibit and all that good stuff, but I'm going to just jump to the question. I was going to give you some history, but jump to the question. The bottom line is there a level of funding to Medicaid that will give private dentists the incentive to see these patients, the poor patients? How much money will it take? And maybe that's something that we can work toward?
I'm convinced that the money saved from emergency room visits for oral pain would fund some of that in states, especially in our state.
If you could put a dollar value on it, that would give us something to work toward.
Well, I would just throw out this number, not as accurate as you're probably looking for, but $200 million spent in one state on emergency room visits, to Dr. Donoff's point, for issues related to oral pain. And the results and the outcomes are not good. Because if you think about the Ohio 26-year-old single dad who went to the emergency room and got an antibiotic and an analgesic, and pain was more important than taking care and was dead within 24 hours. So the results are not great. I think there's money in the system, it's just redirected in the wrong places.
That's why we need an economist in oral health.
Exactly. But good question.
Great question.
We need to do 3 quick things. Thank our speakers again. We want to acknowledge Dr. Reed in her absence. She had to take care of a situation, but we always want to acknowledge Dr. Reed because without her, there would be no us, right? So we'll give her a round of applause. We would also like to thank some very other key people that keep the Reed Scholars as well as the fellowship and all the other many programs that Dr. Reed runs going well. So Jackie and Christine are 2 of, they're not paying any attention to me, of course, but they work in the office and and we have gifts for them that we'll deliver to them in just a moment. And lastly, we would like to thank our sponsors. We have a very colorful slide up there, but again, this symposium was put on in part by their donations and, of course, the continued support, as you heard a few minutes ago, by DentaQuest. But we also have several other key sponsors this year.